I'm a GP from Theale, and forgive me, I've got tracheitis, which means my voice might fail. I've got some water, but I'll go for as much as I can. So we did a project in Berkshire West with the sponsorship of the Strategic Health Authority back in 2009, which led on to a full-on project supported by the Department of Health. So this talk is based on a combination of four people's works: Dr. Rowe, Ed and Sarah, our PWPs, myself, and Judith as director for talking therapies. Let's tell you about the successes that we've had locally and about some of the good news stories that's led from that. So this is about the presentation, essentially how psychology moves on into lead to organic practice, and how it led to a community-based program. And we actually applied for ethics and made a randomized controlled trial to show you cannot put diabetes into a standard program. And then also how we worked in BME communities. Essentially, diabetes is a common problem affecting about... Oh, yes. Hello, hello. No. Oh. It says on. Hello.
Oh.
Any better? Can everyone hear me okay?
Yeah, it's happening. Okay, fine.
Okay. So, thank you. Essentially, diabetes is a common problem. Oh, that sounds a bit better, actually. Diabetes is a common problem. About 3.5 million people are affected. About another 750,000 are affected, but not yet diagnosed, according to prevalence. The condition is staggered, so there's a racial preponderance to people of black and South Asian origin, and white people are least favoured. So the instance of mental health problems in the diabetic population, there's a population study shows about 40% prevalence of symptoms, and something like 15% depression, anxiety rate, of which a GP can detect about 6%. So 6 out of 100 diabetics will have psychological problems severe enough for me to spot in a clinic in those 7 minutes when I'm doing everything else. So in the Berkshire diabetes population, about 35,000, 17,000 East Berkshire, about 16,000 on West Berkshire side. This excellent document came out in 2010, which looked into this combination of NHS Diabetes and Diabetes UK, the largest charity, and it said that actually the psychological problems are expensive to miss. They're expensive to the patient, they're expensive to the GP, they're expensive to society on the whole. And that's because people who are less interested in caring about their diabetes tend to deteriorate, tend to use more services, they come and present, because actually we're paid to actually follow these people. So we know they're doing badly, we tend to tell them off, they tend to feel worse, eventually get to the point that they end up going to hospital because there's nothing else to do. If someone's leg is gangrenous or if vision is gone, then actually my last step is the hospital, by which time it's usually too late. They can only salvage damage. So actually the key point of this document is you try to work with your patient to get them on board. You try to actually care for them in the fullest, completest sense of the word, including their psychological needs. Yes, also apart from increased disease and acceleration of disease, actually there's increased disease burden, essentially amputations, and disability, reduced working life, which means reduced taxes in the healthcare system, so costs are high, productivity is low. It's a bit of a disaster story. So we thought we should address that, and so it was our key condition. Essentially this stepped care model, it doesn't show up very well. Essentially it's just to show that GPs are at the bottom, you see everybody, we're everybody's friends, but from level 2 is IAPT and step 3 and step 2 process, but we were targeting step 2, and we did that because we had to be cost effective. And we had to get a mass delivery program, and we know IAPT is successful. IAPT is a great success story, and everybody's friend. And it's helped a lot of patients, so we thought, why don't we harness this vehicle to actually specifically target the diabetic population? So what did we do in this group? So this is just to say that actually, by doing a psychological intervention, it's evidence-based, that actually you should be able to save money in the system. So let's try and prove it, essentially. There's another quotation that CBT is cost effective for people with long-term conditions and in diabetes, basically Ishmael's work. So, how do you actually get to work locally? Because that's what I'm interested in, basically. Theory is all good and well, but actually if you're targeting IBS population in a clinic somewhere in, out to Hebrides, that's great, but how does it actually relate to my population? I see everybody. So we were going for a generalist population, so that's what we're going for. So that's why IAPT is so good. We did a mild to moderate depression anxiety 6-week group, and we knew that the standard group was already effective on depression anxiety, so that is our baseline. It was good use of resources, and it's one of the nice favoured interventions. So why don't we apply that? So it was a one-step intervention the pilot studies allowed us to tweak the standard model. We did that over 5 groups, about 48 patients, and out of 92 came. And we designed this ideal model that when we went on to actually put forward to an ethics committee and say, could we run a randomized controlled trial? So we get a whole bunch of diabetic patients, and you offer them the standard IAPT intervention where you're not really encouraged to discuss the condition, and the diabetes group you are, and you actually incorporate it. So not only they all had depression and anxiety, but actually the diabetes was encouraged to discuss in the diabetes group, and the not standard IAPT group, it's like any other disease condition, you try to only encourage what you know, and you stick within parameters of depression and anxiety, and touch upon it only if it's relevant, so that it's what's in the PWP's comfort zone. So that's the details of the pilot study. Learning from the pilot, effectively there was a bit of lack of engagement in the group. There was definitely a dropout rate, which was fairly significant, and the BME dropout rate was 100%. So everybody who was black and Asian seemed to drop out. Some of the clients didn't feel it was relevant, didn't feel it applied to them. There was quite a lot of, but over those 5 cohorts, we effectively adapted it, so actually the uptake was better towards the end. And patients weren't able to easily to link up how their diabetes related to their mood. So it's a bit of a big problem. So, particularly when the 4-year program for IAPT says that IAPT needs to move into long-term conditions, how is it actually going to go about doing this? So it was the health psychologist has written this bit. It's about the language and the Socratic questioning, engagement to essentially adapt the group. But the tweaks are really quite mild. It's essentially not ignoring the elephant in the room, and incorporating the diabetes as part of the depression and anxiety, which kind of makes sense. It's a big part of their life. They can't get rid of it. They have to learn to work with their condition, and so actually it's relevant to their anxiety and depression management as well. So a step 2 intervention was introduced, and that was the only specified intervention. Anything that was beyond that would go up to step 3 or back out to the GP or the relevant resource. So if it was medical strategy kind of thing, so an education eating well program, then they'll be redirected that way. They focused on goal setting, problem solving, thought identification, behavioural experiments, and essentially then we applied to the ethics group, because you're obviously taking a group of patients and offering different interventions, so it's cleared by them, and we measured specifically mood, which is a national outcome, and then some diabetes specific psychological questionnaires, PAID and SDSCA. PAID is problem areas, so that's a bad scale, so how many problems do you have, and SDS is how many times you check, actually in a preventative way, so actually how many times you're checking your feet, how often you check that you're taking the right medication on a daily basis, so one's a good and bad scale. And then there was adjustment, so that's the WASAS, Work and Social Adjustment Scale. The Euroqual is a national European measure for quality of life, and that breaks down into the VAS scale and actually a scoring scale. And then on my side, because I have the most sceptical GPs sometimes in their practices, and they're the ones that you have to satisfy, is what evidence is there that actually does any good for the diabetes. And then, of course, money. So study design, we've got 149 patients. We were aiming, which was more than our target, more than we promised. We said 128. They were randomly allocated. We've got 72 and 79 just by. They were offered which group to go to, but they didn't know which one they were going to. That was our randomisation. Interestingly, we found actually the people in the standard group, the standard IAPT group, had less, so there were less problems than the intervention group. So the intervention group is the group that we're interested in, the control group is the standard group, and the people, so the most people to gain would be actually the standard patients. So actually there was, there's a bias towards a null hypothesis that we're not going to find a difference. What did we find? We found, the DWBG is diabetes wellbeing group, and the S is standard wellbeing group. So diabetes, this basically says that psychological measures, both groups did what they were supposed to do. Anxiety and management recovery, it works, which is great on all 3 scores. It does exactly what it says on the tin. That's because the model, the IAPT model works, and actually we tweaked the IAPT model, so of course it works. Adjustment measures, this again shows that the diabetes and standard wellbeing group, they showed significant improvement on both the Euroqual, National Recognised, and the WASA scale, which is another IAPT scale. So people seem to make some reasonable adjustments, which is good. And then on the specific self-caring measures, you can see that general diet, specific diet, and foot care, only the diabetes wellbeing group showed any significant improvement. The standard group showed no significant improvement. So actually, ignoring the diabetes as part of anxiety and depression management is not a good thing. Somehow patients aren't encouraged on getting good measures. And it's actually the cross-talking in the group, that when that's cut, that seems to be the key player here. So the scales at the bottom go exactly in the same order. So general diet's about cardiovascular diet, good heart health, specific diet about diabetes health, so the glycemic index, and foot care. So all significant. And overall, this is the IFCC result. So this is how we actually check for blood sugar control. And this is showing that, I'm not saying that psychology can cure diabetes, which is what my GP critics have come up with. And it's the fact that actually if you work with your patients and you take in a whole package and you look after all the bits of them, actually they work better as an individual and they're more likely to take the medication. They're more likely to do what they set out to do and they feel accomplished and feel empowered. And actually you get a better person who's better treated than the diabetes. So in the control group, you can see it's a less steep line, so it's less favourable. And the intervention group, they were more significantly diseased according to their diabetes. You know, IFCC predicts the amount of disease and the progression of disease. And actually, they got much better control than the actual control groups. The control group's not doing so well here. And then finally, money. So in every argument, unfortunately, GPs now have to have a money hat on. So we have to prove our worth. This project didn't cost nothing. So we have to say that it saves something. And it's good that we're kind of aware of these things now. So we looked at the SUS data. 77% of a diabetes budget is spent on secondary care data. And yes, and so that's why we focused on hospital data, essentially. And the top numbers, hopefully the numbers come out okay. So the intervention groups at the top, and you can see overall, before and after, they seem to spend £186 less per patient for those 79 patients, 64 patients, sorry. And of the control group, 52, there was an overall saving of £83 a patient, which sounds, that's good, you know, IAPT. So IAPT is saving money already in patients, but when actually you include the diabetes in that, actually the saving is 2.23-fold, I think. So every pound you save, you can save £2.23 by including the diabetes. And we're not doing anything different. Same amount of therapist, same amount of therapy time, a little bit of extra training from a GP. No GP was involved. These are PWP-led. So, and it's not a diabetes education program. It's a psychological program, but actually including the condition is important. That's where the government wants IAPT to go. So here's some pretty bar charts to show actually the difference is more substantial in the intervention group. And there was a significant reduction if you use transforms, which is a statistical term. So overall, when you got to the national meetings, I did some net costs as well. So actually, we worked out how much the cost of a group was and took that off. So actually, the saving for a diabetic in an intervention group is £131 on secondary care in the 6 months after they've been treated. But if you compare to control, that's a £16 saving. So depression and anxiety management does something, but does something extra if you incorporate the diabetes as part of that. And that could be as simple as when I'm low, I eat more, which makes me feel better, but actually just linking up and actually that doesn't do so well for my diabetes, as simple as that. Actually my diabetes control gets worse. And actually one of the side effects, my nurse and my GP is going to tell me off. I won't bother going. You know, well, just forget the tablets. This happens, I tell you. So anyway, so then I projected forwards because actually we applied for second year funding, which we've been granted, which is a great success. And then we magnified up, so if I take the 17,000, 19,000 diabetics and work on a 6% detection rate, and maybe 1 in 2 people you can convince to come. Potentially, if these numbers are true and they're sustainable and can be verified and reproduced, then that's potentially a £202,000 saving across the patch. 142,000 if you take off the IAPT costs. So IAPT's, like I say, not free. And these are the number of patients from about 1,000 patients. But it can help and potentially, you know, save lives, save disease. Having patients work better. My entire job, the first line of my treatment is how to get the patient to work better for themselves. And after that, I can start intervening with tablets, injections, surgeons. You know, it's all important. Actually, getting the patient on board and working with you, or me working with them, is the most important thing. The patient feedback seems to be very successful. Many patients have told us that exceed their expectations, makes them think and put things together, and not presuming that they already know, and actually going back to basics. And that they found it nearly impossible to find the most helpful thing. Oh, that's very good. And express feelings frank and fully regarding diabetes, and that some patients wanted longer. And some of my patients have come back and said it was great, and they would like to have. And now they're being encouraged to actually go onto the internet and join up with a kind of a support group with other diabetics that's being formulated. So the IAPT services do listen and start to actually try to respond to what the patients want, but you have to build the need first. So, in conclusion, the pilot was highly successful with the support of the South Central Strategic Health Authority before it dissolved, and it ran a successful pilot where we then trialled through randomised control against the standard IAPT intervention. We proved it was more effective by including the diabetes in a course regarding anxiety and depression management skills. and it was highly effective. I've took out the slide just for shortness, but it was particularly effective for the BME group. So we had a 100% dropout rate in the pilot study. In the control group, the intervention group, we had a 9% BME rate, which is higher than the 7% background rate of the IAPT service. So actually, more patients are likely to be Asian or black. So actually, you should have a slight bias towards the BME population. The randomized control trial showed that self-reporting management was good, and it was compared to the control group, and the quality of life measures, and the IFCC and the costs. But basically, both groups, the control and the intervention, showed that essentially it does what it says on the tin. It's a good psychological group, but only the specialist group actually showed that it was more significant, a significant impact on cost savings and diabetes control. I think it's my last slide. I'd welcome any questions.